On October 10, 2020, Miss Jean, a 35-year-old obese woman, was rushed into the emergency room due to complaints of shortness of breath, substernal chest pain, and diaphoresis. On admission, she stated that she is not physically active and usually lies down watching television daily. Her vital signs were monitored and results were blood pressure 88/42 millimeters of mercury, pulse 134 beats per minute, respiration rate 26 breaths per minute, temperature 98.8 degrees Fahrenheit, and oxygen saturation 83%. 6 liters per minute of oxygen was administered via a high-flow nasal cannula. Chest X-ray showed no abnormalities. 12-lead ECG showed sinus tachycardia. Stat ABGs were ordered and results were pH 7.5, partial pressure of carbon dioxide 30 millimeters of mercury, bicarbonate 17 milliequivalents per liter, and partial pressure of oxygen was 60 millimeters of mercury. Ventilation and perfusion scans showed decreased ventilation and perfusion in the right lung, and a CT pulmonary angiogram showed a large embolism in the right main pulmonary artery. She was then diagnosed with massive pulmonary embolism. Her vital signs were monitored again, and her blood pressure was 82/35 millimeters of mercury, pulse 140 beats per minute, respiration rate 30 breaths per minute, temperature 99 degrees Fahrenheit, and oxygen saturation was 70% despite oxygen administration. She was rushed into ICU where thrombolytic therapy was initiated. Upon arrival at ICU, stat labs were ordered and results were prothrombin time 8.5 seconds, activated partial thromboplastin time 18 seconds, hematocrit 23%, and platelet count 500,000 per microliter.
Good morning. I'm student nurse Walker, and I'll be helping present on diagnostic and thrombolytic agents. I'll be talking about what is thrombolytics, the indication for thrombolytics, the contradictions for thrombolytics, the complications, how does it work, and I'll be going over the diagnostics. What is thrombolytic therapy? Thrombolytic therapy is the administration of drugs called lytics or clot busters to dissolve blood clots that have blocked major arteries or veins and pose a potentially serious or life-threatening implication. Indications for thrombolytic therapy would be massive pulmonary embolism, myocardial infarction, venous thrombosis, arterial thromboembolism, and acute ischemic stroke. Complications. Thrombolytics are predominantly safe. Complications related to bleeding are a major problem. Bleeding, which is usually noticed at the catheterization site, and another complication would be allergic reactions. Contraindications for thrombolytic therapy would be vascular lesions, severe uncontrollable hypertension, recent cranial surgery or trauma, brain tumor, ischemic stroke in 2 to 3 months, and active bleeding with the exception of menstrual bleeding. Relative contradictions can be included: ischemic stroke greater than 3 months prior, active peptic ulcers, the use of anticoagulant drugs, pregnancy, prolonged or traumatic CPR less than 3 weeks prior, major surgery less than or equal to 3 weeks prior, and internal bleeding in 2 to 4 weeks. How does thrombolytic therapy work? Thrombolytic therapy works by converting plasminogen to plasmin, which lies the thromboli, fibrinogen, and other plasma proteins. Therefore, thrombolytic therapy resolves the thromboli or emboli more quickly and restores more normal hemodynamic functioning to the pulmonary circulation. Thereby, this reduces the pulmonary hypertension and increases perfusion, oxygenation, and cardiac output. Here is just a brief illustration of what happens when thrombolytics is used. Here we have the artery. This is the blood that is obstructed by the blood clot. When thrombolytics is used, the blood clot gets dissolved, which restores the blood flow to the pulmonary artery. Go on to diagnostics, which is the practice or technique of diagnosis. Some of the conditions that use thrombolytic therapy use these diagnostic testing. There is chest x-ray, electrocardiogram, ventilation and perfusion scan, D-dimer, and CT scan. First, we're going to talk about electrocardiogram, which is better known as ECG. This is the graphical representation of the electrical currents of the heart. This is obtained by using disposable electrodes strategically on the skin of the extremities and chest wall. This is used to rule out MI and pericarditis. Usually in PE, it portrays itself as sinus tachycardia, T-wave inversion, and PR depression. So when you hook your patient to the monitor, these are some of the signs you will see on the strip. Now we're going to talk about chest x-ray, which is an imaging test. This uses small amounts of radiation to produce the picture of the lungs. Usually, sometimes in patients with PE, their x-rays are normal, but they may have infiltrates, atelectasis, pre-effusion, and elevation of the diaphragm in the affected area. Sometimes infiltrates will be shown as it looks like cloudy or look like smoke on the x-ray. Now we're going to talk about ventilation perfusion scan. This is used to examine the air flow, which is ventilation, and the blood flow, which is perfusion, in the lungs. The goal is to detect the blood clot in the lungs. Now we're going to talk about the D-dimer test. The D-dimer test is used to determine whether the patient has a blood clotting disorder. It is one of the protein fragments produced when the blood clot is dissolved in the body. It is usually undetectable, but when detected, it is in very low levels unless the body is forming or breaking down a blood clot. A negative D-dimer test indicates a highly unlikely chance that a thrombus is present. A positive D-dimer test does not depict whether or not a blood clot is present, but indicates that further testing is needed. This test will be a CT angiogram. The normal values will be 250 micrograms. A CT angiogram is used to obtain images of the pulmonary arteries to detect whether a blood clot is in the lungs. A CT angiogram takes pictures of the blood vessels that run from the heart to the lungs. During this test, a dye is injected in the vein of the arms and travels to the pulmonary arteries to make them appear brighter and lighter on the scan so that you can see if there is a blood clot present.
My name is Student Nurse Rule, and I will be doing the medical management of thrombolytic and pulmonary embolism. Pulmonary embolism is often a medical emergency. Therefore, emergency management is of primary concern. After emergency measures have been taken and the patient's condition stabilizes, the treatment goal is to dissolve the existing emboli and prevent new ones from forming. The treatment of PE may include a variety of modalities, such as general measures to improve respiratory and vascular status, anticoagulation therapy, thrombolytic therapy, and surgical intervention. Massive PE is a life-threatening emergency. so therefore the immediate objective is to stabilize the cardiopulmonary system. A sudden rise in pulmonary resistance increases the work of the right ventricle, which can cause acute right-sided heart failure with cardiogenic shock. Most patients who die of massive PE do so in the first 1 to 2 hours after the embolic event. Emergency management consists of administering nasal oxygen at 1 to 4 liters per minute immediately to relieve hypoxemia, respiratory distress, and central cyanosis. Additionally, intravenous infusion lines are started to establish the routes for medications or fluids that will be needed. Also, a perfusion scan, hemodynamic measurements, arterial blood gas determinations, and spiral CT or pulmonary angiogram and angiography are performed. A slow infusion of dobutamine is administered, which is diluted in 250 to 1,000 milligrams in 250 to 500 milliliters of dextrose 5% in water, 0.9% sodium chloride, 0.45% sodium chloride, dextrose or 0.45% sodium chloride, dextrose 5% or 0.9% sodium chloride, dextrose 5% in water or lactated ringers, or 200 to 800 milligrams of dopamine in 250 to 500 milliliters of 0.9% sodium chloride. Dopamine is administered to the patient to treat hypotension, and these have a dilating effect on the pulmonary vessels and bronchi. The ECG is monitored continuously for dysrhythmias and right ventricular failure, which may occur suddenly. Blood is drawn from the patient for serum electrolytes, complete blood count, and hematocrit. If clinical assessment and arterial blood gas analysis indicates the need, the patient is intubated and placed on a mechanical ventilator. If the patient has suffered a massive embolism and is hypotensive, an indwelling urinary catheter is inserted to monitor urinary output. Small doses of intravenous morphine, 1 to 3 milligrams every 5 minutes until desired relief is obtained, or sedatives such as 1 to 1.5 milligrams per kilogram, IV bolus maximum of 3 milligrams per kilogram of lidocaine, followed by a 4-to-1 ratio maintenance infusion at 2 to 4 milligrams per minute, are administered to relieve the patient's anxiety, to relieve chest discomfort, to improve tolerance of the endotracheal tube, and to ease adaptation to the mechanical ventilator. Using elastic compression stockings or intermittent pneumatic leg compression devices, which reduces venostasis, these measures compress the superficial veins and increase the velocity of blood in the deep veins by redirecting the blood to the deep vein. Anticoagulant therapy is initiated by administering drugs such as heparin, warfarin, and sodium for managing acute deep vein thrombosis and PE. Heparin is used to prevent the recurrence of emboli, but has no effect on emboli that are already present. It is administered as an intravenous bolus, 5,000 to 10,000 units, followed by a continuous infusion initiated at a dose of 18 units per kilogram per hour, not to exceed 1,600 units per hour in otherwise healthy patients. The rate is reduced in patients with a high risk of bleeding. The goal is to keep the partial thromboplastin time 1.5 to 2.5 times normal, or 46 to 70 seconds. Heparin is usually administered for 5 to 7 days. Low molecular weight heparin drugs such as enoxaparin may also be used. Warfarin sodium administration is started within 24 hours after the start of heparin therapy because its onset of action is 4 to 5 days. Warfarin is usually continued for 3 to 6 months. The protothrombin time is maintained at 1.5 to 2.5 times normally. Anticoagulation therapy is contraindicated in patients who are at risk of bleeding, for example, those with gastrointestinal conditions or post-operative or postpartum bleeding. Catheter-directed thrombolysis is used to treat vascular blockages and improves blood flow by dissolving abnormal blood clots. A blood clot or thrombus can block off blood supply to certain parts of the body and cause serious damage. It uses X-ray imaging and a catheter to guide special medication or a medical device to the site of a blood clot to dissolve the blockage. Catheter-directed thrombolysis is used to treat blood clots in arteries and veins resulting from thrombosis in an arm or leg artery that has severe narrowing due to atherosclerosis and deep vein thrombosis, a condition in which a blood clot forms in the main vein that returns blood flow from the arms or legs back to the heart and lungs. Laboratory results. ABG's result will indicate respiratory alkalosis in a patient with pulmonary embolism due to the patient hyperventilating to try and inhale oxygen that the body is being starved from. However, hyperventilation or tachypnea causes them to expel too much carbon dioxide, which causes blood pH to increase and the partial pressure of carbon dioxide to decrease. When this occurs, the kidneys will start to excrete bicarbonate to lower the pH level, causing a decrease in bicarbonate as well. Prothermin time is used to determine if the blood is clotting normally. Prothermin time measures the activity of the clotting factors from the extrinsic pathway and common pathway, which is located where clots are produced by the liver. It basically assesses the synthetic function of the liver. The normal range for prothermin time is 10 to 14 seconds. The international normalized ratio is similar to the prothermin time. However, it is a calculation based on results of a prothermin time and is used to monitor individuals who are being treated with the blood thinning medication or anticoagulants, such as warfarin. The normal range of INR is 20 to 39 seconds. INR within the normal range indicates normal coagulation. A high INR indicates less coagulation, which means that the patient bleeds easily. A low INR indicates high coagulation. Activated partial thromboplastin time measures the time it takes for a blood clot to form. Normally, when you get a cut or injury that causes bleeding, proteins in your blood called coagulation factors work together to form a blood clot. The clot stops you from losing too much blood.
Okay, class, so reviewing the case study again, I would just like to point out a few clinical manifestations associated with pulmonary embolism. So normally patients usually experience some degree of dizziness or decreased level of consciousness, and this is all due to low oxygenation because the brain is not being perfused and it needs oxygen immediately. So whenever patients get like an emboli in the lungs, it can cause acute pleuritis, which causes the patient to feel chest pain. Additionally, the occlusion from the emboli causes blood to backflow into the right side of the heart, causing an increase in heart rate because the heart is compensating by pumping harder to perfuse the organs. However, because there is inadequate oxygenated blood to perfuse the body, it is not effective, causing a decrease in blood pressure. Therefore, the patient hyperventilates to try and inhale oxygen to perfuse the body. Additionally, patients normally have a degree of ventilation and perfusion mismatch due to the blood clot occluding the pulmonary artery, causing it to be hard for deoxygenated blood to pass through the artery to go into the lungs to become oxygenated. This slide here shows all the diagnostic tests we performed on Ms. Jane and her results, as well as the interpretations. So basically, Ms. Jane had a chest x-ray, but her chest x-ray came back clear. So when the chest x-ray came back clear, we then knew, okay, we had to perform more diagnostic tests because we need to figure out what's going on with her so we could treat her properly. So we did a ventilation and perfusion scan. So on the ventilation and perfusion scan, it showed that she had decreased ventilation and perfusion of the right lung. Basically what this meant was that she had a VQ mismatch. Why she had this VQ mismatch was because this decrease in ventilation basically indicated that she was not bringing in enough oxygen to meet her body's metabolic need for oxygen. Therefore, the blood circulating around the body was very low in oxygen. This is a major problem because this means that the vital organs like the kidneys, brain, the heart, the lungs, and the skin were being deprived of oxygen. Therefore, they will not be able to perform their function effectively, which can lead to further complications. Normally blood circulates around the whole body, and whenever we breathe in, we inhale oxygen, then we exhale carbon dioxide. So we know that because she was having this decrease in ventilation and perfusion in the right lung, we know that okay, this means that some type of blockage was going on in the lungs. So we know something was blocking, we just didn't know what it was. But we was thinking, along the lines of it being a blood clot. So we did a 12 lead ECG too. We hooked up to the monitor. When we did that, it read a sinus tachycardia. Basically, why we saw a sinus tachycardia was because the large emboli in the lungs, it caused obstruction of blood flow, which led to an increase in pulmonary vascular resistance, which resulted in tachycardia. Therefore, that's why she was hyperventilating. She was tachypneic, basically, like her respiration rate was so high because this large emboli was obstructing the blood flow, and then how she had this increase in pulmonary vascular resistance, causing her to hyperventilate and have tachypnea and all of that. So basically, when we saw the sinus tachycardia, we say, okay, she have an embolism. There's a pulmonary embolism. But just to further our diagnostics, just to further our test, just to confirm, to make sure this is what we know she have, we did a CT pulmonary angiogram. And this CT pulmonary angiogram, it showed a large embolism in the right main pulmonary artery. And normally the blood vessels are not supposed to be occluded, and they're supposed to have normal perfusion, but we wasn't seeing that here. Therefore, we diagnosed her. When we saw the emboli, that's how we really confirmed that our diagnosis to say, okay, she has a pulmonary embolism. This slide here shows all of the labs that was performed on Miss Jean, including her results, the normal readings, and the interpretation. Normal prothrombin time is 10 to 14 seconds. And the normal activated partial thromboplastin time is 20 to 39 seconds. Miss Jane's reading was for her prothrombin time, it was 8.5 seconds, and the activated partial thromboplastin time was 18 seconds, which were very low, indicating that her blood is clotting faster than normal. ABGs were as follows. The normal reading, so pH normal range is 7.35 to 7.45. The partial pressure of carbon dioxide should be between 45 to 35 millimeters of mercury. Bicarbonate should be between 22 to 26 milliequivalents per liter, and the partial pressure of oxygen should be between 80 to 100 millimeters of mercury. Miss Jean results was pH 7.5, which was high. Her partial pressure of carbon dioxide was 30 millimeters of mercury, which is low. And her partial pressure of oxygen was 60 millimeters of mercury, which was also low. So basically, because this emboli was in her lungs, even though she was inhaling oxygen, the oxygen wasn't being perfused because of the blockage. Therefore, she started to hyperventilate. When she hyperventilated, this hyperventilation caused her to expel too much carbon dioxide, which caused a decrease in her partial pressure of carbon dioxide. And this decrease in her carbon dioxide level caused an increase in the pH. That's why it was 7.5. So basically, whenever a patient is hyperventilating, she expelling too much carbon dioxide, blood pH increase, the body then tries to compensate. So in this case, the body tries to compensate by the kidneys starting to excrete bicarbonate in hopes to decrease the pH level. Therefore, as we can see, the bicarbonate level decreased to 17 milliequivalent per liter. This patient is said to be compensated because her body did compensate with the decrease in bicarb. We know she is in respiratory, some type of respiratory disorder because her partial pressure of carbon dioxide decreased, as well as we know she is alkalotic or in respiratory alkalosis because of the increase in the pH. So therefore we say that this patient is in compensated respiratory alkalosis because the kidneys excreted the bicarb in hopes of decreasing the pH, meaning that it's trying to compensate for the high increase in pH by excreting bicarb to lower it. So that's why we say it's compensated, and then she's in respiratory alkalosis, like we say, because her partial pressure of carbon dioxide decreased, as well as the pH is high, it's spiked. Hematocrit level, the normal range is 35 to 47%. and the patient result was 23%. So basically it was low, indicating that she was anemic due to the fact that the red blood cells are not carrying sufficient oxygen due to low perfusion. And then the platelet count, normal range is 150,000 to 400,000 per microliter, and Miss Jean's results was 500,000 per microliter, which indicate that she is in reactive thrombocytosis. And basically reactive thrombocytosis is when the body produces too much platelets, hence the formation of blood clots. Good day, class. My name is Danae Quant, and today I will be presenting on the nursing assessment, the nursing management, and nursing education for thrombolytic therapy. So, as a nurse, it is important to remember that whenever we are initiating thrombolytic therapy, we have to be able to provide care for the patient before the infusion, we provide care during the infusion, as well as after the infusion. According to Ali et al., prior to the administration of thrombolytics, the nurse should obtain a complete health history. This health history should be inclusive of any recent surgeries or trauma, because if the patient had a recent surgery or trauma, he or she will be at risk for bleeding if thrombolytic therapy is initiated. The nurse also obtains the patient's known allergies to determine which medications can be administered to avoid the patient from having an allergic reaction. It is important to find out the patient's drug history to determine if the patient is taking any anticoagulants, because we all know that anticoagulants are blood thinners. Therefore, if we administer thrombolytic therapy while the patient is taking anticoagulants, it can increase the risk of bleeding, as well as we want to know if the patient is on any antiplatelet drugs, because antiplatelet drugs, they prevent the blood from clotting. We also need to know about any drug interactions. Additionally, vital signs such as blood pressure, respiration rate, pulse, temperature, and oxygen saturation are obtained, and a detailed head-to-toe physical assessment is performed to gather baseline data to compare the patient to during the infusion as well as post-infusion. The nurse also obtains and interprets laboratory tests such as activated partial thromboplastin time, prothrombin time, hematocrit, and platelet counts. Therapeutic nursing management. The therapeutic nursing management. Intravenous lines and arterial lines need to be inserted prior to initiating thrombolytic therapy. One of the arterial lines should be designated for drawing of blood. And then the intravenous line, we insert them so that we can administer the thrombolytic agents through the IV line. We never administer thrombolytics through arterial lines, because if the patient have any active bleeding, we won't be able to apply direct pressure on that site. Therefore, we use IV lines. A Foley's catheter should be inserted before initiating therapy so that we are able to drain the bladder once therapy has begun. The nurse assesses and records the infusion site for hematomas and hemorrhage. She do this every 15 minutes for the first hour, then every 30 minutes for the subsequent 2 hours, and then hourly until the intravenous catheter is removed. The nurse evaluates the patient's pulses, sensation, the color, as well as the temperature of both extremities with each vital sign test. Vital signs and the sites are commonly evaluated to find possible complications. It is important to remind the patient to keep the extremities still and straight to prevent internal injury. The nurse also keeps continuous cardiac monitoring using an electrocardiogram during the infusion prior to monitor for hypotension as well as dysrhythmias, which may occur with reperfusion of the myocardium. So, post-infusion management includes assessing important signs, distal pulses, and infusion site regularly as required. We need to assess the patient's response to therapy, where we look at any symptoms, see if the symptoms subsided. We look to see if the patient have any complications. We monitor their vital signs, as well as we draw their blood so we could check their labs, like their tests. We want to ensure bed rest for 6 hours to reduce the risk of internal bleeding. We want to assess the puncture site for hemorrhage. We want to evaluate body fluids as well as urine, feces, and vomitus for any evidence of bleeding. If the patient is experiencing minor bleeding, we want to apply a direct pressure and continue to monitor the patient. However, if the patient has a major bleed, the nurse should discontinue thrombolytic therapy and any anticoagulants, then apply direct pressure onto the site, and then notify the physician immediately. Normally, if a patient has a major bleed, some physicians may order antiplatelet drugs such as aspirin. So we'll administer it based on if the physician ordered it. We need to report any manifestations of reocclusion, as well as any changes in the ST segment, chest pain, or dysrhythmia, because early recognition of reocclusion is vital to save the myocardial tissue. Okay, class. So we already talked about the nursing assessments. We talked about how we manage our patients. Now we have to also talk about one of our most important roles as a nurse, education. According to Ali et al., patient education is very important for the proper implementation of thrombolytic therapy. The nurse instructs the patient about procedures and their necessity prior to initiating these thrombolytic agents. The nurse needs to inform the patient of the frequent vital signs that must be taken during the therapy. The nurse instructs the patient that activity will be limited during infusion and that pressure dressings may need to be applied to stop active bleeding. The nurse advised the patient that their cardiac rhythm will be observed using an electrocardiogram during the treatment, as well as the nurse must instruct the patient about the increased risk of bleeding once the therapy is initiated, as well as activity restrictions and frequent monitoring during the time. Additionally, once perfusion is restored, anticoagulant and antiplatelet therapy is initiated to prevent further clot formation and repeat occlusion.
Current trends with thrombolytic therapy. As mentioned earlier, thrombolytic therapy rapidly breaks down thrombi or emboli and restores more normal hemodynamic functioning of the pulmonary circulation, thereby decreasing pulmonary hypertension and improving perfusion, oxygenation, and cardiac output. The urokinase regimen for PE consists of 4,400 units per kilogram as a loading dose given at a rate of 90 milliliters per hour over a period of 10 minutes, followed by continuous infusion of 4,400 units per kilogram per hour at a rate of 50 milliliters per hour for 12 hours. The streptokinase regimen for PE consists of 250,000 units as a loading dose over 30 minutes, followed by 100,000 units per hour over 12 to 24 hours. For Retaplase, IV boluses of 10 units each are administered 30 minutes apart. These are the medications administered to dissolve massive embolism in the pulmonary artery. Additionally, in order to diagnose a patient before initiating thrombolytic therapy, diagnostic tests must be performed. Equipment commonly used to diagnose patients with pulmonary embolism includes a chest X-ray, electrocardiogram, pulmonary angiogram, and ventilation perfusion scan. Additionally, intravenous and arterial lines are used to administer thrombolytics and monitor blood pressure respectively.